Thank you very much to Menetox and EPAT for inviting me. I'm proud to collaborate this assembly. My presentation topic is mud honey. Mud honey poisoning, not also this presentation, my presentation topic, also my scientific life main topics. I will explain some my expert. I like there to no conflict of interest. First, let's see some chronologic old writing and ancient writing about mud honey. In ancient and old writings, we first seen Xenophon. Xenophon has a book called Anabasis. In this book, he mentioned about the mud honey. He told that his soldiers who ate mud honey looked like drunk people. This is first used mud honey word in the past. First we seen mud honey word in this book. Second, we seen Strabo. He is also an historian in ancient time. Strabo also told this book, his book, Pompey's army was destroyed by feeding mud honey. This war Strabo's mentioned about is near the Trabzon, like Xenophon mentioned about this war, his war. Centuries after this ancient history writers, Mr. Coleman said that he gave medical attention about, explained some case, 14 cases, which 3 of them died. This is important for us because this mortality is first described these books, these relators. The distribution rhododendrons at methanopoisoning cases in Turkey. Grantosine comes from the rhododendron flowers, and this makes the honey poisoning in Turkey. Plants belong genus rhododendron have wide distribution area in Black Sea region, which extends from the Marmara region to Caucasia. We see. This area is rhododendron ponticum area. This area is rhododendron luteum area. There are remarkable harmony between the distribution areas of plants genus rhododendron and the areas where poisoning cases. Worldwide, when mud honey poisoning cases are analyzed according to countries, it is seen that the most cases of mud honey poisoning occur in Turkey. Nepal is second country. South Korea comes third. As we see, Turkey is first one. Nepal and South Korea is second and third case we see. Methane poisoning produced in this country can export Europe, Asia, and others countries. Because of this, some poison case can be appears in this area. Out of the Turkey, Nepal, and South Korea, we can see methane poisoning cases. For what we use, people use methane. Methane generally consumed but accidentally in Black Sea region. People don't know how it contains grantoxin or not. Methane can also consumed as alternative therapy for health problems such as digestive system, hypertension, sexual dysfunction, wound healing. Methane also used to diabetic patient for blood sugar regulation. When they use it as an alternative therapy, it can be poison this person. The poison effect of methane originates from toxic compound called grantoxin. Based on the literature, so far we 60 grantoxin types, and their glycoside have been isolated from the various Acacia plants. Primary toxic compounds are grantoxin 1 and 3. Primary toxic 1 and 3. Physical symptoms from methane poisoning appear after dose-dependent latent period of several minutes, approximately 3 hours. Patients exposed to low-dose grantoxin typically recover within few hours. In more severe cases, symptoms may persist 24 hours or longer, may be required medical treatment. Grantoxin are capable of binding the group 2 receptor regional voltage gated sodium channels. Grantoxin only binds the activated conformation of sodium channels. After binding of the receptor, grantoxin prevents inactivation of sodium channel. This activated conformation allows the influx of sodium, and this is stop the membrane activation and neural activity. The main symptoms believed to caused by continued sodium channel activation, cell deposition, and hence stimulation of the vagal nerve system. Depending on this, various cardiac conduction disorders may develop, such as varying degree of heart block, nodal rhythm, complete atrioventricular block, and second degree heart block we can see. The main common symptom in methane poisoning, cardiac symptom methane poisoning patient is sinusal bradycardia. Also, clinical characteristic. What is the main clinical characteristic of methane poisoning patients? We can see in emergency department this patient. Main symptom this is hypertension, bradycardia, nausea or vomiting, sweating, dizziness, impaired consciousness, fainting, blurred vision, or diplopia. We can see. Diagnosis based on patient history and clinical finding. SMS system need diagnostic tools not in used in Turkey now. Maybe in the future we can use this diagnostic tool. There are similarities in clinical status between methane poisoning and cholinergic poisoning. It is important to efficiently difference between the two types of poisoning, emergency department, to initiate appropriate and effective therapy. Biochemical data which was obtained in this study do not support the hypothesis that methane poisoning should regard as cholinergic poisoning. It's different. Only the same is atropine treatment is useful, methane poisoning and cholinergic poisoning. Clinical characteristic, we seen one patient, methanopoisoning related asystole. This is first case and only one case to after the poisoning we seen asystole. After we after this after we published this case report, we seen a film, famous film, Sherlock Holmes, named Sherlock Holmes, mentioned about our case report. One of my colleagues said me that people made films your study. Did you see the Sherlock Holmes film? I said no. They said me that you should you have to watch Sherlock Holmes film. Let's watch this part of film. This one. In this film, they said that as we wrote on my our case report, they said that in this film, methane poisoning, very well-known poison, which can temporarily block heart rate. They said also this film, this fragment. But we can't hear. No. Okay. Ne diyorsun sen?
Bir sonraki saatte. Devam ediyorsun.
What's the treatment in this poisoning? We only two tools, atropine and IV fluids we use. Standard ACLS protocol if bradycardias appear. Supportive treatment, atropine and IV fluid we use for treatment. There is no specific antidote for gram toxin. Although symptoms and signs can be alarming and sometimes life-threatening, useful supportive care with electrocardiographic monitoring, normal saline infusion, as I said, we used if complete heart broke and appear, we can use cardiac pacemaker. A lot of research has been done on mud honey poisoning in Karadeniz Technical University Medical Faculty Department of Emergency Service, Emergency Medicine. The high incidence of, let's look at some of it. One of them, dose-dependent effect of ground toxin in cardiovascular system. Second one is analgesic effect of methane poisoning, and is ground toxin directly responsible methane poisoning associated seizure? Does methane poisoning require hospital admission? Clinical review of methane poisoning with flower methane, and also maybe 5 or 6 more example. The honey, the poison, and the weapon the topics presentation was we have. Are there any new project about methane in this our department? Yes, we have new projects. We are doing some new studies. The most important one is project developed to diagnostic kit for methane poisoning. I think the last one, this project, the last project is the best one for methane poisoning disease. Thank you very much.
Thank you. Thank you.
The front flower is Rhododendron ponticum. The back is Rhododendron luteum. This view is Black Sea Mountains. Thank you.
Thank you. Are there any questions? Yeah.
Because actually, because we are facing with this patient. Actually, we have a patient with same symptoms after injection of honey.
Can you just keep the mic near your mouth?
My question is how we can differentiate this is hypotensive bradycardia, this from the honey itself, or it is contaminated honey, because you know that a lot of honey is contaminated with other substance, which can cause bradycardia and hypotensive. How we can differentiate between this?
I think you mean old honey don't poison. You mean?
No.
How can we differentiate of what?
I mean, many manufacturers, they are producing honey, they are contaminated with other substances, which can cause bradycardia and hypotensive. How we can
like what other symptoms you mean?
Because what I want to say, because what I remember that when I'm talking about that, what the case was, I'm showing that the honey was definitely contaminated with something. I'm not sure what was that one, but definitely was contaminated.
His question is, can there be any other contaminant which can cause the similar kind of?
As we don't have any contamination.
You don't
honey,
think that
honey.
there is
Yes.
any such?
Or contamination is only ground toxin.
Okay. Okay. I think it's better that you can maybe discuss your problem with him at later stage. Thank you so much. It was a wonderful talk. Let's give him. So I thought we were kindly done with the presentations, but we have Dr. Hussain, who's from Iraq, and he's going to present on thallium poisoning, his experience.
Yes, our next speaker, Dr. Hannah Berkbauer. She's a nurse midwife and nurse practitioner. Oh, nurse midwife and nurse practitioner who focuses on international health programming. She's a consultant with Integral Global and currently stationed in Bangladesh, focusing on expanding access to care and quality improvement within the Rohingya and health and host communities, incorporating telehealth platforms into low-resource settings.
I can probably do it without, I think. Oh. So I have to use that. Okay. Everyone for being here. That was a great talk, giving sort of the history of telehealth, and I'm going to talk a little bit more about telehealth, but in a different capacity. The telehealth work that I've been involved in has been in low resource and vulnerable settings, so slightly different from the EMS perspective. So just sort of a broad definition of what is telemedicine. It's technology-enabled health and care management and delivery systems that extend capacity and access. So what does that mean? It just means that basically we're utilizing technology to expand the reach of providers and care access to patients in settings that they wouldn't normally have it. So we saw in the previous presentation, that the telemedicine was used in the field. I'm talking about actually taking it to rural settings or places that maybe are conflict zones or other things like that, where a person in the US or maybe couldn't even go, or providers can't get to. So why telehealth? These options provide sustainable medical expertise to those with the most vulnerability. So the quality of care increases, they have greater access and lower or no cost, because oftentimes when it comes to telehealth, the person on the other end of the camera is doing it for free, or it's a part of a package. So it's low to no cost, which is nice. So 50% of the world's population lacks adequate health care. And that's, we see typically in the global south, but also telehealth is being mobilized throughout the United States in rural areas as well, and in other countries that are considered high income due to lack of access. So I always like these world mappers. I don't know if anyone else uses them, but I think they do a good job of showing distribution, specifically in regards to the health workforce. So this is sort of an example of the distribution of physicians globally. So you can see, right, that higher income countries tend to have more physicians, which means that patients are generally going to have better access. It doesn't always guarantee that, right, because we know that oftentimes in countries like Bangladesh is a high-income country, but for example, in Bangladesh, 70% of the physicians are actually working in urban areas, while 60% of the population in the country lives in the rural areas, right? So it's disproportionate. But this is what, we see the continent of Africa becomes very, very small. Southeast Asia, like India, looks large in Bangladesh, but the distribution isn't even. And then we look at nurses, which also, are now being moved into telehealth platforms to do consulting as well. And you can see that the distribution isn't quite equal. And the same for midwives. So sort of background on how telehealth, what I've been involved in is working is devices are provided. So the organization that I've worked closely with has been, it's called InTouch, that's the platform. And there's some pictures of the devices throughout the PowerPoint. And then the World Telehealth Initiative. So World Telehealth Initiative is a partner of InTouch. And basically, InTouch created this technology, and the World Telehealth Initiative has then linked them up with providers who will see the patients, from the other side of the world, which is pretty cool. Then extensive training on the use is conducted, and then the expertise based on what the service utilization is going to be will then be provided. So I'll talk about more like utilization of the telehealth in a few slides because there's a lot of different ways. It's not just providing clinical care or consultations. It's now being used in low resource settings in a variety of other ways as well. And then these devices that I've been working with specifically they're trying to use internet as much as possible because it's more cost effective, but they're also using satellites as was mentioned in the previous presentation. Sure. Hello. Okay. So these are a few ways that we are currently utilizing or uptaking the telehealth models. So direct clinical, well, I say direct clinical care, it's a little bit more indirect, right? But for clinical care, scheduled expertise consultations, emergent high acuity cases. So for example, we might have somebody on call that you can ring into or that you can call into with a video capacity as well. Education and training is something that we're utilizing these models for pretty extensively, especially in settings that are unstable where someone who's a trainer can't actually go into. Technical assistance, so I'll tell some stories about some technical trainings that have been done. And then disaster preparedness and management, real-time response, and then a lot of mentoring. So this is actually a picture of students who were utilizing telehealth resources out in a village. You can't, they kind of cut it off, I'm sorry, but there actually was a telehealth device. This is in Tanzania, and they're out doing trainings with a local community, sort of training of trainer models. So it's actually, that device was using satellites. And this is what's called a mother's club. So it's a place where mothers can come and gather in these rural communities in Bangladesh. And they've got telehealth devices that actually allow someone to provide them a consultation for different things that they might be experiencing. So they might have a day where there's a dermatologist that can provide a consultation with one of the devices. This is an example of, you can see one of the devices down at the bottom here. And so not only was the training recorded, but this was really important for these midwives because they actually practice on an island. So it's an island that takes about 45 minutes by boat to get to the mainland from, and there's no emergency transport service. So there's not like an emergency boat or anything like that. Basically, if there's an emergency, that person has to get on what's called a sampan and make their way. So these midwives, there's 6 of them that basically run this labor and delivery ward, and they need to be able to do everything. And that's a challenge for them. So what we were able to do is do extensive trainings and mentorship, and also they have a telehealth device where they can call in to somebody who's on the mainland at any time for backup, which is different than they ever had access to before. And actually there's been a documented decrease, in some more severe morbidities, and then mortality hasn't changed, but that's a result of other factors. And so this is, you can see a nice graph representing fistula clinic and the mentoring sessions, and looking at, they were doing the same amount of surgeries throughout the entire period, but they were able to do more independently after trainings, and less mentoring sessions were then required. And then this was reported on yesterday using the telephone consultation service at the tertiary care hospitals in Lebanon for the toxicology exposures and the impacts of the reach of, having access to those services to help patients get specialized expert care. And then one of the projects that I've been working on has also been in the Rohingya refugee camp. And so when the Rohingya, I don't know if everyone is aware of that crisis, but basically in 2017 in August, there are about 1 million people who made their way from Myanmar to Cox's Bazar, Bangladesh, as a result of genocide in Myanmar. And so of course, at that point, there was no infrastructure, there was no healthcare services available to them, and the influx of providers from Dhaka and other cities throughout the country, they weren't specialized providers. So they may have been physicians or other trained healthcare personnel, but they weren't specialized. And so telehealth devices were able to be moved in pretty quickly, and satellites were used so that there could be access to things like a dermatologist, which oftentimes people say, why do they need a dermatologist? Acne is not an emergency. Well, when you have a skin condition that is life-threatening, it is an emergency. And so having the access to the dermatology, for example, was actually pretty important. And then in relation to more of a toxicology or sort of perspective, I don't know if anyone's ever heard of YABA, but YABA is a drug that there's been a big issue with the import of it through the camps, and there's been a lot of overdoses. And so it was actually, when that first started to happen, they looked at it from an epidemiology standpoint and figured out what was going on, and then employed telemedicine actually to consult and help treat some of these patients, because there's only 4 tertiary level hospitals throughout all of the camps serving about 1 million people. And so those providers didn't have access to emergency or response resources, so they were calling into experts actually in the US who could help them through that. And then there's the option of clinical consultation, so specialized expert care. This is the picture doesn't tell you what this patient has, but this guy actually has MDR-TB, and no, he's not wearing a mask. But this patient was waiting for his call to actually talk to a specialist in the US, and he continues to come back and get his treatment. And the device, actually, he can see him, and it's this young lady in the picture. They've hired a telemedicine implementing physician. So she basically just runs the telemedicine device. She does the assessment. She helps move and maneuver everything in collaboration with the provider who is on the screen. And this is just an interesting picture because it's a dermatologist looking at a patient who is following up. So it actually has created continuity of care, whereas like many times before, maybe a provider had flown in from wherever, saw the patient, and then would never be back again. But what this also does is creates the option of seeing that patient again and again, and the patients, they do come back. So this is important in terms of these low resource settings and the provision of healthcare, because the idea is that there's the possibility of preventing about 8.6 million deaths a year, which is a lot, by providing access to specialized care and resources. So the idea also is that with everyone that is interested in telehealth coming together and providing these expertise and consultations, that you can actually transform healthcare that is currently being provided in low resource, low income settings where the options to see providers or receive trainings and other specialized services aren't available. It's really impactful, and it has the ability to offer patients things that they wouldn't normally have. And so, like I said, I'm working with Integral Global, and then in partnership with InTouch Health and World Telehealth Initiative. So thank you. If anyone has questions, I'd be happy to answer.
Yeah, we can take questions from all the speakers now. Yes, do we have a microphone?
Dr. Hussain, you have 20 minutes. Please stick to the time.
Yeah. Where is my presentation, please? Okay. Yeah. Thank you, Doctor. It's my appreciation to be here. I am Dr. Hussain Hammoudi, the director of Baghdad Poisoning Control Center. In fact, from 2008 up to 2012, 15, we have many cases presented, about 60 cases presented to our center. Sometime might ask, this is the most likely presentation. Alopecia is one of the presentation of thallium poisoning in chronic cases. Sometimes skin hyperpigmentation also occur, but it is not usually start like that. Usually thallium starts in acute stage with after entering to the GIT symptoms, presented with GIT symptoms in acute. Then in second day, after 48 hours, usually presented with painful ascending peripheral neuropathy. With the time, with the course, after a few days, the painful ascending peripheral neuropathy changed slightly and slow progressive into motor neuropathy. So the patient after 1 week or 2 weeks might have numbness and paresthesia and usually end with paralysis. This is the effect on the lower limb, which is the most likely affected by thallium. Of course, the mechanism of thallium is usually attributed to its analog to potassium ion. I mean, it enters and deceives the cellular membrane instead of potassium because of similar charge and similar size. It entered to the ATPase system, and that illustrates why it is usually affect the hair follicle, because ATPase is responsible for energy production, and this is due to lack of this energy production. Usually the hair is fall, and the epilation usually starts at the 10th up to 3 weeks. 10th days after exposure up to 3 weeks. Sometimes when the amount ingested is so large, it might cross the blood-brain barrier, and the most likely affected oculomotor nerve, the third cranial nerve, and the patient presented with the dropping of upper eyelid. Here, there is 2 case study. One of them, the most common, a famous case report that is published all over the world. It is about Al Jawiya Sport Club. When they ingest thallium, which is contaminated with the piece of cake usually introduced to them during the celebration day of that club. Those 2 families, in fact, admitted to the emergency departments of Al-Kindi hospitals. Their complaint was GIT symptoms, but it was fruitless. They didn't manage well. In the 4 days, they admitted to another hospital within the medical city complex, to the Baghdad hospitals. At that time, they asked me to see and examine the patients. On examination, this is a good example of acute thallium poisoning. All of the patients looked terrified, exhausted, diaphoretic, and the child was admitted to the intensive care unit. The member was 6 at that time. Bilateral painful ascending peripheral neuropathy on all of them. They have severe burn, described their burn as if they are walking on a pen or a hot coal. Yeah, of course, the tendon reflexes was normal. Babinski reflexes and other reflexes was normal at that time. Abdominal reflexes, normal. Ptosis in 2 persons. Yeah, pleuritic chest pain in 1 person, and all of the patient, of course, ECG normal and other examination is normal. In fact, this is the questionnaire that I have asked at the time. How many days they were suffering? The answer was 4 days. This is the day 4. What type of food they were shared? Yeah, they said to me, and a cake introduced to them. Who had ingested the largest quantity? Because I want to compare the quantity that had ingested with the clinical presentation. The answer was that one have severe painful ascending neuropathy and ptosis. That means he had ingested a large amount of thallium which crossed the blood-brain barrier. So differential diagnosis at that time was arsenical compounds and thallium. Botulism also. We sent for a stool culture and bacteriological study to exclude the Clostridium botulinum and Guillain-Barré syndrome. In the second day, we arranged for laboratory workshop. 6 samples were withdrawn from these 5 samples, and another 2 negative samples. All of them were positive, as you see. This is the name, Zainab and Muhammad Rasul. He is the big boss of Al-Jawiya Sport Club. This is the thallium test were done in my lab. If it is clear, a pink color test usually appear, which indicate the positive results. Of course, we use dithiazide and sodium potassium tartarate cyanide reagent in this test. Okay. After we finished the diagnosis, the absence of a Prussian blue at that time, and unfortunately, we sent them to another Jordanian hospital. And the guideline management were prescribed at that time. A Prussian blue should be given orally. Hemodialysis should be done for them. Potassium infusion, it is controversial. Some of them said that it might exacerbate the neurological symptoms, and some of them mentioned that it might shorten the bedridden of the patients. This is the Prussian blue potassium ferric hexacyanoferrate. This is a case. The another case, please. Yeah. Mustafa Latif, 13 years old male. In fact, presented to the Mansour Pediatric Hospitals. The relevant gave history that he eat hamburger and sweet, and his daughter were died the day after ingestion. Of course, the Ministry of Health and other pediatricians asked for my help at that time. This is the Ministry of Health. This is the examination. All things were normal except sinus tachycardia. The patient looked hallucinated, terrified. Of course, he has painful ascending peripheral neuropathy, but no alopecia. And with dark hyperpigmentation of both hand and face. This is an abnormal, but it rarely happened with thallium. In more than 80 cases, just we have 2 patients presented with such dark hyperpigmentation. Of course, the patient treated with thallium, with the Prussian blue, and also we add, this is laboratory finding. All biochemical tests were normal, except thallium. The patient has hypertensive, which were treated by captopril, in addition to Prussian blue, or IV fluid, Potassium, of course, given IV infusion, but then it replaced by fruit juice in order to replace the thallium. Usually the patient have hypokalemia during the course of illness. On 7 days, another test were done, which was negative, but the patient kept on the same treatment for at least 3 days. This patient presented 1 month after exposure. We add on discharge Neurobin, multivitamins, and zinc sulfate. After 1 month, the patient completely returned to normal, but he still has some pain in the lower limb. But it usually, according to the literature, it might disappear after 1 year at least, 9 months up to 1 year. Thank you.
Thank you.
If there's any question, please.
Yeah, they're very interesting cases. I just have one question for you.
Yeah.
How did they get, all the cases got
Thallium.
thallium in food? What was the intention and how did they get that?
Most likely criminal.
Criminal.
Criminal, yeah. Because during the wartime, and ISIS, some members, some families, some of their family members belong to ISIS, they might to kill other, which belong to policemen or governments.
And is thallium available?
Yeah, it is not available on the markets, but it is used as a rodenticide in the neighboring countries, in Syria and Iran.
Okay.
So it was used by intelligences during the time before war, before 2003, by Saddam regime to assassinate the others.
Okay, so that's very interesting because I personally have no experience. I would have maybe thought of ascending paralysis, neuropathy, arsenic, which you mentioned, but the alopecia...
arsenic was negative in our test,
yes.
in my lab test.
Any other questions?
Any other question, please?
If there are none, thank you very much, Professor Hussain, and I must give him a big round of applause. I must thank all the speakers, Paul, Chuck, Hussain, and Dr. Abdul Qadir for a wonderful session. With that, we conclude today's day, and we meet again tomorrow morning at 7:30. Thank you very much.
The commonest source of CO poisoning in Turkey?
In Turkey, there is furnaces and heat stoves, most of the common cause. We don't have that much suicidal carbon monoxide poisonings. Big majority of the cases are accidental poisonings because of like I said, furnaces or heat stoves. But we don't have the exact data, so it's anecdotal data.
Any problem with using the hyperbaric oxygen therapy? Is it easy to send the patient there?
Yeah, we have we have several centers in Istanbul, and I'm speaking for Istanbul. So if you had a patient with carbon monoxide poisoning and you think that he or she needed hyperbaric oxygen treatment, you can connect with hyperbaric chamber doctors, and they gladly accept it. But in some outbreaks, we have some delays for treatment because of the patient overload.
Any other question?
Yes. She will talk about caustic injection. Dr. Betül Başaran. She graduated from Hacettepe University Faculty of Medicine and certified as an anesthesiologist from the same faculty, Department of Anesthesiology and Reanimation. Dr. Başaran is an associated professor of anesthesiology and currently working in Konya Training and Research Hospital. She is interested in critical care and toxicology. Yes, please.
Good afternoon, my colleagues. It's my pleasure to be with you as an anesthesiologist. And I come from Konya, the city of Rumi, that's located at the center of the Anatolia. Okay, pardon. You see. I declare that I have no conflict of interest about my speech. My topic is corrosive ingestion. As you know, it is rare and potentially devastating event, and there is limited experience, personal experience about it. Uncertainty persists about the best clinical practice, and wide range of cases can be seen from the mild to severe, and the CT scan is accepted as a best methodology for the management of the cases according to worldwide scientific literature. And esophageal stricture, as you may know, is the main common consequence. During the management of these cases, multidisciplinary approach is accepted. And you may see what clinicians must be participate to manage these cases. I am the anesthesiologist, the second one. And the first one always is the emergency care physicians. And, pardon. As you may know, two age groups are most risky group. First one is children aged between the 2 and 6 years. About 80% of the cases are children between 2 and 6 years, and 20% of cases are adult. They are aged between the 30 and 40 years. And two main agents responsible for the caustic ingestion strictures, caustic ingestion burns. And the first one is the strong acid. Strong acid may cause coagulative necrosis, esophageal scar formation, and also strong acid can cause prolonged gastric contact. The second one is alkali. And the alkali can cause the cofactive necrosis, but the difference from the acid is the alkalis can cause in all the GI tracts, can affect all the GI tracts. It's the difference from the strong acids. Major determinant of the outcome, as you may guess, is the quantity. Early contact of the poison control center is must. Why must? Systemic effects of the corrosive agents can affect the medical situation of the patients. As you may see, hypocalcemia, hyponatremia, hypokalemia, and acidosis are seen in these patients. And as you may guess, the pathological changes seen in all the gastrointestinal tracts, especially in the esophagus. If we mention about the management strategies, primary aim of this management strategy should be the survival, and secondary aims are to prevent early complications, to prevent late sequelae, also to provide nutritional anatomy and quality of life. Pardon. And I want to mention about the initial approach because I know that especially in the initial approach times you are the emergency physicians include these cases. Identification of the corrosive agent is most important. Time from the ingestion must be questioned, and the evaluation of the context must be asked to patient, whether it is accident or intentional. Co-ingestion of the drugs must be questioned, and additional risk factors related to patients must be asked to the patients or the nearest. we should make some maneuvers according to increase the esophageal passage, but we should not make to attempt neutralize the pH of the caustic ingestion. The effectiveness of nasogastric tubes controversial. Some scientific data try to use it, but some not. Some of them not. Evaluation of gastrointestinal injuries. In case of evaluation, distinguishment is most important. And signs, unluckily, signs of the digestive perforation are rare, and according to it, symptoms are not correlate with the signs. So it shows us signs and symptoms. Signs plus symptoms do not show the full necrosis. Some of the patients may be admitted to emergency department with a better condition, but in these patients we can also see the full necrosis of the esophagus or the stomach. In these patients, some of the blood-related parameters can be changed. You may see here. And the second blue one is important for the anesthesiologist because during the perioperative period, we must deal with severe acidosis and renal failure with management of fluids. And esophagogastrostomy means state of emergency management, but it should be done between the 3 and 48 hours. Later, it's not important at the later cases. Zargar classification used during the flexible gastroendoscopy. You see here the Zargar classification. Endoscopic grading can predict systemic complications, respiratory failure, emergency mortality, also provide nutritional anatomy, but endoscopic grading have two major drawbacks. One of them is inability to predict accurately depth of necrosis, as I said before. The second one is endoscopic grading is mostly observer dependent. And after the 24 and 48 hours, potential disadvantages of misinterpretation can be seen. I want to mostly talk about the computed tomography. It is new data for me, I think. I know before this speech presentation, I know only the endoscopic grading. But during my search about this speech, I learned about the computed tomography, and I learned about that the World Society of Emergency Surgery support application of CT. It surprises to me too much, I think. There are some conflicted data. Some of them related to endoscopic grading is the best. Some of them related to computed tomography grading is the best. But the Lancet supports both of them. The last data from the Lancet also supports, firstly, the computed tomography if needed. If the computed tomography shows us the full thickness necrosis, then the gastroendoscopy should be done. Management algorithms, nearly scientific data supports management algorithms based on computed tomography, as I said before. In all the cases, the computed tomography should be done. After the computed tomography, the related data should be added to gastroendoscopy related data. But computed tomography also has two disadvantages. One of them is renal failure, and the second one is the allergy to contrast agents, as you may know. I want to mention about little information about the emergency surgery. Emergency surgery, as you may guess, has high mortality rate, has high morbidity rate. Also, the Bad factors that affect patients related to surgery are advanced stage tracheobronchial injuries, emergency esophageal resection, extended resections, and severe derangement of laboratory test results, as I mentioned before. If you look at the surgical procedures, we mostly see in the operating theater the esophageal gastrectomy. It is accepted as the most common emergency procedure. The second one is the damage control surgery. In the caustic ingestion, patients can be accepted as a major trauma patients. As you may know, major trauma patients should be dealt as a damage control surgery, not only one-sided surgery. The caustic ingestion patients can be accepted as there.
Please take the sentence.
Efendim?
Take the presentation, finish, please.
Okay. Partial gastric resection is not recommended, and concomitant necrosis of organs can cause extended resections. Non-surgical management, as I mentioned before, from the non-surgical management, early nutritional support is very important, and total parenteral nutrition must be inserted to non-surgical management. Delays, sequelae, as you know, hemorrhage, fistula formation, and malignancy are delayed sequelae. In low resource settings, limited access to medical expertise is seen and poor follow-up seen. In low resource settings, primary aim should be prevention of malnutrition and gastrostomy. And future directions are there: optimal management of corrosive ingestion, quality of life after caustic ingestion, and preventive measures. Thank you.
Thank you, Dr. Bambasharan. Do you have any question or contribution? Please.
I guess I have a question and a comment. The question is, did you come across any use of steroids and antibiotics in such cases?
Yes, I have read about the steroids and antibiotics, but they have no place during the routine management of cases.
Okay, then
it should be think case by case. In the routine practical cases, they have no place for the steroids or the antibiotics.
So, and then the comment basically is a majority of these injuries that have been related to caustics will have a very bad outcome despite the measures that you are doing initially. And so preventive measures, probably the standard of care, and increase the awareness about how difficult these cases should be addressed in a very confirmative way.
Yes,
you are right.
Thank you. Other question?
Thank you for your presentation. I want to ask you, I met with lots of causative ingestions in my clinic, and most of the time pediatric surgeons are stopping the oral intake and waiting for 24 hours. So what's your emergency surgery rates for caustic congestion in your cases? Yes. In your hospital?
I have 1 year training period in the pediatric surgery department before the anesthesiology training. And the pediatric surgeons mostly deal with cases with waiting, not the operating. They wait. Not operate. In the Konya Training and Research Hospital, we did not take any pediatric patients for the emergency resection.
Thank you. Other question? Any other question? Thank you very much.
It's going to talk about the Colchicine poisoning. Please welcome Dr. Azura Shiki. I'm not sure, I'm sorry if I pronounced it incorrectly.
Azura Shiki.
Shiki,
yeah.
Okay. Please welcome Dr. Kiki.
Thank you. Thank you, Chairman.
Dr. Kiki is a medical toxicologist working at the Pavia Poison Control Center in Italy.
Thank you for the presentation, and thank you to the organization to invite me to talk about colchicine poisoning. So let's start talking about colchicine. It's a drug derived from the alkaloid component of the plant Colchicum autumnale. Colchicine binds the tubulin dimer and inhibiting the formation and function of microtubules. So, with consequent anti-inflammatory and antimitotic properties commonly used in therapy for the gouty arthritis or familial Mediterranean fever or other rheumatic disease. It's a poisoning with high mortality rate, and it can occur after intentional overdose, therapeutic errors, or ingestion of plant containing colchicine that are often confused with edible plants. The most widespread in Italy is Colchicum autumnale, often collected instead of wild garlic or Allium ursinum. So to my knowledge, different species of Colchicum are present on the MENA region with a huge variability, and all plants are poisonous with the high concentration of colchicine in bulb, corn, and seeds. And this is an example, the species of Colchicum present in Turkey with difference to autumn and spring. So in order to understand the basis of colchicine poisoning treatment, it is important to point out some toxicokinetic characteristics of colchicine. And the first one, because of the antimitotic action of tubulin, because on the microtubules, because of the presence ubiquitary of the microtubules in cells, of course, colchicine has a really narrow therapeutic index. Is a variable bioavailability between 25 and 50%, a volume of distribution of up to 21 liter per kilo, plasma protein binding between 10 and 50%, is metabolized by liver with biliary secretion and enterohepatic cycle, and with a renal elimination of 20% and elimination half-life variable on renal elimination rate from 10 to 37 hours. So evaluate reliable prognosticator is important to early identify patients at risk of death who should benefit from aggressive treatments. It's therefore important to evaluate the ingested dose because it is known that if patient ingested less than 0.5 milligram per kilo of colchicine, death rate is less than 5%. But if patient ingested more than 0.8 milligram per kilo of colchicine, death rate is increased to 90%. Of course, this does not apply with plant ingestion, but only with drugs. So other known prognosticators in colchicine poisoning are prothrombin index less than 20% or white blood cell count more than 80 gram per liter in the first 24 hours, or the onset of cardiogenic shock of ARDS in the first 72 hours. And the exact prognostic value of plasma colchicine concentration is still unknown and I think is not currently available in emergency practice. So, drug-drug interaction may cause clinical picture more severe than predicted when, in example, colchicine is co-ingested with the cytochrome inhibitors 3A4 or PGP inhibitors. And clinical picture of colchicine poisoning is characterized by three phases. The first one is called gastroenteric phase, from 2 to 24 hours from ingestion, and is characterized by abdominal pain, vomitus, and diarrhea with consequent volume depletion and peripheral leukocytosis. The phase 2, that is the most dangerous for the patient, and is the one in which patient could die because of the onset of cardiovascular shock, respiratory distress, myelosuppression, thrombocytopenia, rhabdomyolysis, and multi-organ failure. If patients survive from this phase, we observe the third phase, that is the recovery phase, with rebound leukocytosis and alopecia. So, based on this information, it is important to identify the key points of the management, especially in the first hour from ED presentation, and I want to start by discussing a case that I consider explicative to this objective. This is the case of a 42-year-old woman for which Pavia Poison Control Center was called from extra-hospital emergency setting, and because the patients had taken 30 minutes before a dose of 0.85 milligram per kilo of colchicine, so of course a potential lethal dose. So the first indication was perform gastric lavage in the first emergency room available. 1 hour later, the patient arrived in a near emergency hospital, a little hospital of Italy. So the potential severity of the evolution was explained and the importance of the decontamination was underlined, but what happened was that because of the discovery of a pregnancy test positive, the patient was transferred to a bigger hospital with an OB-GYN service, but gastrointestinal decontamination was still not performed. So unfortunately, patient died on day 5 of hospitalization. Yes, so sad. But I think it's very important because starting from this, I want to focus your attention on the first hour management of colchicine poisoning, in which is important history evaluation, of course, suspect colchicine poisoning, calculate ingested dose, consider drug-drug interaction, start laboratory test monitoring, but mainly is important to perform gastrointestinal decontamination. And as soon as possible after ingestion and after emergency room admission. Gastrointestinal decontamination should be considered even some hours after ingestion, and even if many hours after ingestion if patients co-ingested opioids or other peristalsis inhibitor. So gastrointestinal decontamination should be based on gastric lavage, oral administration of activated charcoal, multiple doses of charcoal because of the enterohepatic cycle, and whole bowel irrigation. So, I made the photo. So the rest of the treatment is mainly based on the phase of the poisoning, is based on is supportive treatment, so fluids in case of vomitus and diarrhea, vasopressor in case of cardiogenic shock, mechanical ventilation in case of ARDS, hemodialysis that is ineffective because of the large volume of distribution, but should be considered if the patient has acute kidney injury, and of course colonial growth factor or transfusions in case of myelosuppression. So other considerations should be made on exceptional treatment like ECMO. There are reported some cases with favorable outcome, but colchicine poisoning results in multi-organ failure independently from cardiac failure, so actually evidence is still lacking. And the anticorpal fragments anti-colchicine that are still unavailable. So in conclusions, colchicine poisoning is characterized by high mortality rate, should be considered if patients came to emergency room with the gastrointestinal symptom after ingestion of self-collected plants. It's important to evaluate early known prognosticator to early identify patients at risk of death, and gastrointestinal decontamination must not be delayed and should be considered also late decontamination if co-ingestion, as I said, of opioids or other peristalsis inhibitor. Consider drug-drug interaction if you see a clinical picture severe more than prognosticated, and treatment is mainly supportive and needs to be aggressive. Thank you.
Any question? Have you had any experience with the ECMO?
Yes and not. Not in Italy. I have experience in France, but unfortunately was a patient with amphora who died, because actually, as I said, ECMO acts on the cardiac failure, but not on acute kidney injury, rhabdomyolysis, and the multi-organ failure. So unfortunately, no. But was a patient with late arrival at hospital. Actually, is the most important thing. If patient absorb all colchicine that had taken, the mortality rate is really high.
Okay. Thank you for your presentation.
Thank you.
Chairman of Emergency Department at Hamad Medical Corporation, Qatar. Please welcome.
Thank you very much. Good evening, everybody. I know it's late, and I hope everybody still have some power. So it is basic, so it will not be a lot of information there, but let's see if we can get some benefit from it. So first of all, let me ask anyone from the audience, how many cases of methemoglobin you diagnosed in the last year? So anybody diagnosed methemoglobin in the last 1 year? By raising hand? So nobody. So that means it's rare disease. That's making my life easy. Okay. So I'm talking now about methemoglobinemia. I don't have anything to disclose. We'll talk about what is methemoglobinemia and what is the most common agent that induce methemoglobin in the blood and information. And if there is any doubt, how we treat it, how the presentation, we'll go through that in very brief. So let's start with the case. This is a real case, came to us in Qatar. It's a 27 years old man who has ingested some chemicals for intentional, for suicidal attempt. He brought by ambulance with complaint of dizziness and drowsiness. And the things he ingested was this chemical. It calls indoxacarb. It is non-organophosphate insecticide. It was used there widely for agricultural issues, and he ingested quite a large amount of it for suicidal attempt. So this is the first physical examination of it. He is not tachycardic, blood pressure was fine. Saturation, which was significantly low to 82 to 87% in 100% room air. And he was severely cyanosed, but he was GCS is still okay. So ECG done for him, it was normal. There was no ECG changes. But we found in the lab investigation that his methemoglobin level was 79, which is very, very high. Okay, one of the highest level that diagnosed in our region. Maybe there is one in UK with Dr. Kamor, 91 you got? 90.3. So this is the maximum was diagnosed. Anyway, so this patient is having a very high level of methemoglobin, and he is already symptomatic. He is cyanotic, and he has a dizziness, some headache, tiredness, and he was actually not in the main tertiary hospital. He was in a peripheral hospital. And they started do intubation for him. Then they call a poison center for such case. And we told him, okay, this is a case already you diagnosed. So he starts treatment. Okay, so let's have some basics about physiology. This is the hemoglobin, deoxygenated hemoglobin when there is no oxygen. And when there is a binding of oxygen, it binds to it and change it to oxyhemoglobin. With extra oxygen, the bond of oxygen become more tight. Okay, what happens in methemoglobinemia is that there is oxidant that oxidize the iron from ferrous to ferric, and that oxidant form cannot bind the oxygen, it bind the water. And then there will be a formation of functional anemia, where there is enough hemoglobin, enough oxygen, but it's not delivered to the tissue because of this problem. Okay? So the clinical manifestation, as we mentioned, it actually depends on what stage or what is the percentage of methemoglobin. It can come with chocolate cyanosis, chocolate colored. Patient may present it with headache, CNS manifestation, sometimes GI upset, dyspnea. It may reach in a high level to a CNS seizure or coma or sometimes, if not treated well, it may go to death. Okay, so it depends, as we mentioned, is to the level. Usually the level below 20, no symptoms or very mild cyanosis, and up to 20%, you can see the cyanosis clearly, and patient may have mild symptoms of nausea, some dizziness is there. If it reaches to 50, the cyanosis will become more profound, and the symptoms become more headache, more dizziness, nausea, vomiting, dyspnea, and in severe cases up to 70, it has become with CNS manifestation of seizure, coma, and the cyanosis become more severe, more clear, and more than 70 usually is lethal. So it is a significant problem, so that leads to death. So we need to recognize it, and we need to do some investigation. So usually the color of blood, it is chocolate color. This due to the presence of methemoglobin level very high, and it's actually correlate also with the percentage of methemoglobin in the blood. Okay, ABG usually it has a normal partial oxygen pressure, but the saturation is very low because the saturation machine, it is actually reading the wavelengths of the oxygen in the blood. That's caused something called saturation gap, and that helps us also in diagnosing the methemoglobin. Okay, so then you do for either ABG or VBG, whereas usually in new machines have a methemoglobin level, which is the diagnostic. So basically, usually the patient with an exposure to the forming agent of methemoglobin, plus the clinical presentation, that will give you a clear clue what is going on. Methemoglobin causes usually either a congenital, like this cytochrome B deficiency or reductase deficiency, whereas actually the reduction of methemoglobin to the normal hemoglobin, and this is usually the mechanism of action, because in the body there is a usual up to 1% production of methemoglobin on normal basis, and this mechanism will reduce the methemoglobin level in the blood if there is no agent that increase the dose of methemoglobin. Okay, so acquired is a very long list of medications, chemicals, and a lot of things. And you can see dapsone is one of the most common anti-malaria. We treated methemoglobin with amyl nitrate, and amyl nitrate can cause methemoglobinemia also. And there is, which is a well-known nitrate, which we are using for chest pain and other things. It can cause, and anything with nitrogen and nitrate can cause methemoglobinemia, like a fire, smoke inhalation. So not only CO poisoning, but it can also comes with methemoglobinemia. So as we mentioned, the treatment is simple and is gold standard, methylene blue. Methylene blue is antidote of methemoglobinemia. And it can use for other uses also, and we put the methemoglobinemia down in the list. Okay, so the pharmacokinetics, the mechanism, maximum effect is up to 30 minutes. If we use it in small doses, we get our reflex of oxidizing agent to hemoglobin again, but if we are using it in high concentration, we actually producing methemoglobin again. So elimination by bile, feces, and urine. So what is the dosage? And when we use it usually in very high concentration, more than 20, and in the patient is symptomatic. So we give it in a dose 1 to 2 milligram per kg over 5 minutes, slow infusion. Okay, and till the cyanosis is resolved, usually within 30 minutes. But this is not the final point we are looking for. It's actually we repeat the level, okay, and we see it's actually dropping down, okay. So caution in G6PD, because methemoglobinemia in G6PD patient can cause hemolysis. So if there is a need, real need, then we need to use it with caution, with very small dose of 1 milligram per kg only. And we keep rechecking methemoglobin and hemolysis pictures, okay? And the side effects, as I mentioned, is according to the dose, how much we are giving. Okay, back to our cases, we give 2 milligram per kg for him, and the cyanosis and the clinical improvement was so fast, within 20 minutes. Patient was intubated in the second day, and he was admitted to a psychiatric hospital because of his suicidal attempt. By this, I conclude my lecture, and happy to receive any question.
Any question? No? Because we are running out of time, so thank you so much.
Thank you.
Next presenter, medical toxicologist and also board certified in emergency medicine. He also obtained postgraduate diploma in medical toxicology from Cardiff University in the United Kingdom. Please welcome Dr. Walid. I'm sorry, Dr. Awad.
Thank you very much. Assalamu alaikum. We're going to go within the coming 10 minutes fast through this subject, which is the aluminium phosphate. I think they put it, the moderators and the organizer, they put it in this session because they know the severity of this substance. I don't have anything to disclose. We're going to go in this lecture through the background, the epidemiology, the toxodynamic, the clinical presentation, the diagnostic workup, and the management. First of all, aluminium phosphate is one of the fumigants, which is non-specific pesticides applied to kill and control rodents, insects, weed seeds, and fungi anywhere in the soil, structures, crops, and grains. And it have different chemicals, physicals, and mechanism of toxicity. Aluminium phosphate is the most common one. It have different metals. It's, the most common is the aluminium, but there is zinc, magnesium, and calcium. It is, as we said, used for protect grains held in soils, ships, and during the transportation. Because of its low cost and high effectiveness, freedom from toxic residues, and lack of adverse effect on the seed's viability. That's why they use it widely. In the last 35 years, the cases of aluminium phosphate increase dramatically, and this is mainly because of the advanced transportation and manufacturing of this substance, as well as start to be used as a suicidal substance for suicidal purpose. It is very common in agriculture society, India, Sri Lanka, Iran, Jordan, and Morocco in the region. And that's obviously because it is available in that society, and it is less and rare in Europe and North America. Aluminium phosphates, the first picture, it is the most widely available. It is, as it there in the picture, the greenish tablet with the garlic order, and each tablet has 3 grams of aluminium phosphates. And it contains also some ammonium carbamates and urea. The zinc phosphides, as in the second picture, look like dark gray powder or crystal. The odor is like rotten fish. Calcium phosphates, as in the third picture, look like reddish brown powder. Aluminium phosphate, actually, when it is mixed with the moisture, ambient moistures, it will give the phosphine gas, which is the main cause of the toxicity, the cytotoxicity, and which is going to lead to the death later. If it is mixed with water, this will lead to rapid release of the phosphine. And this is significant because mainly in the suicidal attempts, they intend to take water on top of these tablets, and this makes the condition faster and make the severity worse. The mechanism of toxicity is it will be through blocking the electron chain transport by inhibiting the cytochrome oxidase and formation of reactive free hydroxyl radicals and reduce the glutathione. This will result into lipid peroxidations, protein denitrations of the cell's membrane, and interfere with the enzymatic function and synthesis of protein. It also causes acute respiratory distress syndrome through direct injury to the alveolar capillary membranes and by producing oxidative injury. It also have effect and inhibit the cholinesterase activities, but this not to the clinical significant level. The toxic dose for the zinc metals, it's around 1 gram, and the death can happen if there is around 4 gram ingestion. For the aluminium phosphates, 500 milligram can be fatal. The smell, the garlic smell, it is very common with aluminum phosphates. So if you smell it in your department, you have to think about aluminum phosphates. The clinical manifestation, it depends on the dose, the route of entry, if it is ingested or inhalated, the time to exposure, how long, especially for the inhalation. And the aluminum phosphate, it have rapid effect than the zinc phosphate. So the zinc phosphate, the symptoms can happen even after 40 minutes. The clinical manifestation, if it is mild, then it will be GI symptoms. It will be around, it will be mainly about the GI symptoms: nausea, vomiting, diarrhea, discomfort of the abdomen, epigastric, and tachycardia as a result. Moderate to severe symptoms, it will involve multiple systems, the GI, and this even can reach to hepatic failure, cardiovascular, hypotension, palpitation, cardiovascular collapse, and dysarrhythmia. CNS, secondary to the hypoxia, there will be dizziness, confusion, convulsion, and coma. Respiratory, tachypneic, and ARDS. Renal failure, metabolic acidosis, airway irritation, especially in inhalation. The diagnostic test, what is in this slide is usually, actually it measures the complication of this substance into the body, the CBS and the coagulation profile to check for the intravascular hemolysis, methemoglobinemia, and DIC. The chemistry, looking for the hypokalemia, hypo and hypermagnesemia, hyper and hypoglycemia, acid-base balance, metabolic acidosis, the main, and there will be also respiratory acidosis and lactic acidosis. Acute kidney injury, we expected in these cases, chest X-ray to check for the ARDS. ECG it is very common to see ECG change in these cases, but it is variable. Tachycardia is the most common and to start with. Then there will be T wave and ST change. Ventricular and atrial tachyarrhythmia is common. Echo to measure the effect on the heart. There will be a dysfunction, dilatation, hypokinesia, and akinesia of the left ventricles. As a toxicologist, we don't recommend to do a specific test for the physogene to measure the phosphine in the blood or in the urine because it is rapidly oxidized. But for some reasons, medico-legally, you may need to do that. The most specific and sensitive test is the gas chromatograph. Also, silver nitrate test can be done through the gastric contained and exhaled breath. Treatment start with decontamination. Inhalation, for inhalation cases, the best is to remove the patient from the source and supply oxygen as needed. For the cutaneous exposure, remove the clothes and try to decontaminate with water. Don't forget the eye. For ingested cases, the best to be done within the first 1 or 2 hours. There is a limited evidence about the activated charcoal, but if it happened within the first 1 hour, then no harm to do it. There is experimentals talk about oral administration of sodium bicarb to prevent the conversion of aluminium phosphate to phosphine. Also, there is a case report suggested using potassium permanganate as an adjuvant to oxidize the phosphine to non-toxic phosphates. Vegetable oils and liquid paraffin in vitro suggested inhibit the conversion of aluminium phosphate to phosphine, and there is also single case report. Secondary contamination, definitely we are recommending everyone to have his precaution, but you have to keep in your mind that the particular mask will not prevent phosphine from reaching to you. And there is studies from India. It showed that the staff, hospital staff there, although they didn't have using their specific precaution, but there is nothing, no positive effect on them. There is no specific antidote for treatment. The main treatment is conservative and supportive treatment till the toxin leave the body. Shouldn't be delayed to confirm the diagnosis. And according to the symptoms, the treatment, the arrhythmia using antiarrhythmic, shock, try to use to be guided by the CVB and wedge pressure. Use vasoactive sub-agent according to the need, pacemakers and mechanical support according to the need. The ARDS, ventilatory support. Metabolic acidosis, you can use the sodium bicarb, hemodialysis according to the need, and don't forget to correct the electrolytes. Some studied about use of NAC in acetylcysteine. There is experimental in animal, and then human studies show some beneficial. Brodoxime, both the phosphine and aluminum inhibit acetylcholinesterase, as we said earlier, but to a level not significant. Further study needed in this subject. Hyperbaric oxygen, experimental data show that it improves the survival time of rates and poisonous rates, and with no change in the mortality rate. Magnesium sulfates act as a cell membrane stabilizer factor and reduce the incidence of fatal dysarrhythmia. Antioxidant effect and combat with the free radicals, and this is controversial. Hemodialysis to help the effect of the renal failure cases and to clear the acidosis. Insulin and glucose, it is suggested by some investigator because of it, the effect of insulin promote the energy and produce production of carbohydrate and restore the calcium flux, which improve the myocardial contractility. Trimetazidine, this is help in approach the BVCs and bigeminies. This is in case report, and act as preserve oxidative metabolism, which need further investigation. Intra-aortic balloon pump to help the pressure. ECMO in circulatory failure, not formally evaluated. And thank you.
Thank you for your presentation. Any question? No. I have seen some country recommend using the coconut oil to lavage instead of using like fluid. For water.
Actually they do it from the local experience, but there is no proven study for that. If it will not help, it will not harm. Yeah.
I would think so, because oil can cause pneumonitis as well as the patient aspirate. Yeah. Right. Thank you so much.
Is currently working as emergency medicine consultant in Ankara University Faculty of Medicine, Department of Emergency Medicine. Yes, please.
Good afternoon, everyone. I will thank the organizing committee and scientific committee for the great conference. I will talk about methanol poisoning for the golden hour management in the ED. Methanol, also known as wood alcohol, is a commonly used solvent in various solutions. But in Turkey, we see methanol in imitated labeled alcohol. A commonly used organic solvent contains in perfumes, photocopic fluid, windshield washing fluid, and perfumes also. Methanol is a component of the many industrial solvents and poorly adulterated alcoholic beverages. Methanol poisoning is a common problem worldwide, especially in the lower socioeconomical countries, and methanol may cause outbreaks. Methanol is relatively low toxic, but metabolism is formic acid is a toxic. First, upon ingestion, methanol absorbed in the gastrointestinal tract rapidly, then metabolized in the liver. First, methanol transformed the formaldehyde with enzyme alcohol dehydrogenase. Is a slow reaction. Then formaldehyde transformed to formic acid with enzyme aldehyde dehydrogenase. And lastly, formic acid oxidized to carbon dioxide and hydrogen, presence of cofactor tetrahydrofolate. Last enzyme, formic acid to the carbon dioxide to the hydrogen, carbon dioxide and water, a very slow reaction. So in methanol toxicity, formic acid accumulates and causes metabolic acidosis. Who is at risk? Children. Accidentally overdoses of any solvents containing perfume, windshield washing fluid. Suicide attempts with methanol is uncommon. Methanol toxicity may be seen in alcoholic persons. Alcoholic persons consume methanol as a substitute for ethanol. And developing countries like ours, imitated, labeled alcohol or homemade alcohol may cause methanol poisoning. In a recently publication from our clinic, an ingestion is very, very high. But in this case report, we report a transdermal methanol intoxication. 58-year-old woman presented to emergency medicine with dizziness, diplopia, nausea, vomiting. She uses a methanol-containing solution for knee pain. In Turkey, we say that resho yağı in fluid for food heater. We treated this patient with ethanol, sodium bicarbonate, and hemodialysis, and completely resoluted. No sequelae. Initial symptoms of methanol toxication generally occur after ingestion of 12 and 24 hours later. This latency is due to enzymatic reaction and may be affected with concomitant and ethanol ingestion and volume of methanol ingestion. Methanol blood peak levels 30 to 90 minutes after following ingestions. Initially, methanol toxicity manifests like ethanol toxicity, inebriation, ataxia, disinhibition. Following a latent period, patient may develop headache, nausea, vomiting, epigastric pain. At later stage, drowsiness to obundation and coma may occur. Seizures may occur due to metabolic derangements and brain injury. Blindness is a very well-known complication of the methanol toxicity. Vision loss is due to formic acid. First, we see flashes of light and blurring, and then scatomata and complex loss of vision may be seen. When we think about methanol toxicity, any patient with any causes altered mental status with acidosis we think methanol toxicity, ethylene glycol intoxication, cocaine poisoning, inhalant poisoning, complex partial seizures, carbon monoxide poisoning, in keeping in mind these patients. Basic workup includes finger stick glucose, acetaminophen salicylate levels, electrocardiogram, pregnancy test. Electrocardiogram is important for the toxic alcohols. Ethylene glycol causes QT prolongation, and methanol does not. Specific workups are arterial blood gases, electrolytes and anion gap, BUN creatinine, serum ethanol level, serum osmolarity, methanol, ethylene glycol, and isopropyl alcohol levels, if available, and pancreatic enzyme. Methanol toxicity can cause hemorrhagic pancreatitis, a very common unreported cases. Serum osmolarity first increase, then decrease, accompanied with increase in anionic gap. Methanol toxicity affects the basal ganglia, primarily putamen. Bilateral putaminal necrosis and varying degree of hemorrhages can be seen in brain CT and brain MRI. This is not specific for the methanol toxicity, can be seen in stroke and Wilson disease. Prompt medical care is key to avoid complication of methanol toxicity. Also, antitherapy and hemodialysis is key. Supportive care, airway, breathing, circulation is essential. Antidotal therapy with either fomepizole or ethanol must be started as soon as possible. And hemodialysis is the definitive treatment of the methanol toxicity. Early consultation may be needed, especially in nephrology, neurology, ophthalmology, toxicology, and sodium bicarbonate. Sodium bicarbonate improves metabolic acidosis. Its effect formic acid to the format, conversion formic acid to the format. This may reverse the visual deficits. Format cannot easily damage the retina and optic nerve, but formic acid damages the optic nerve and retina. Dose of sodium bicarbonate is initially 1 to 2 milliequivalent per kilogram in intravenously bolus. Maintenance dose is 20 to 40 milliequivalent per hour. Antidotes, if available, we prefer fomepizole or ethanol. If unavailable, ethanol. Both of them inhibit the enzyme alcohol dehydrogenase. Fomepizole is superior to ethanol because easy to dose, easy to administer, rare side effects. Its disadvantages of the fomepizole is its high cost. Loading dose is 15 milligram per kilogram intravenously. Maintenance dose is 10 milligram per kilogram every 12 hours for 2 days. Ethanol difficult to dose. Frequent testing and infusion adjustment needing, and ethanol irritates veins. Its more limiting effect is sedative and behavioral effects because ethanol inebriates and aspiration risk rises. Hemodialysis removes both methanol and formic acid. Indications are high anion gap, metabolic acidosis, evidence of organ damage, especially visual changes. Cofactor therapy may be outlined. Optimize the non-toxic metabolic pathway for the elimination. Doses is 15 milligram in every 6 hours. Thanks for your attention. Any question?
Thank you, Dr. Young. Any question or Eddie? that okay. We have seen recently in our country methanol poisoning is an important issue. Methanol is an important issue. Yeah. Any question?
Hi, thank you. Just on one of your slides, you suggested that the visual defects can be corrected by sodium bicarb. I'm not sure how accurate is this. And the second point, as far as I know, although formic acid being implicated in the visual sequelae of methanol poisoning, it's not fully understood, because formaldehyde, which is one of the metabolites of methanol, which end up leading to formic acid, when people get poisoned by formaldehyde, which was more common in the 70s and 80s, they did not get visual defects. So the notion that formic acid is the culprit is, as far as I know, it's not 100% accurate, and also that's applied to the sodium bicarb. I don't know what's, if everybody else has any other opinion about
it. Visual deficits is due to formic acid's effect on optic nerve and retina, and sodium bicarbonate transforms the formic acid to the formate. It not readily diffuse the optic nerve and retina. I can think this maybe reverse the visual symptoms. I don't know the mechanism. I don't know.
Okay, thank you. Any question? We listened to important issue from very valuable speaker. Unfortunately, this section ends here. Thank you for listening. And
thank you for everyone. So next one is the break, and then we will come back in 15 minutes, okay?
Unfortunately, Dr. Tharwat El-Zahran is ill, and she have to be in her room. So we have the great pleasure to welcome Dr. Ritrak Ohong. Ritrak is the residency program director in the emergency medicine department of Vajira Hospital in Navaminokhadhiraj, sorry for the pronunciation, university in Bangkok, Thailand. He did his fellowship in the US in the Emory program with Ziad Qadzi, and he's specialist of QT measurement with all the methods and QT interpretation when they are influenced by drugs. And he's responsible for the AACT, ACMT, and EAPCCT work group that is in charge of recommendations to measure QT, and we are waiting for these recommendations soon. So he will present us his lecture dedicated to the diagnosis and management of drug-induced QT prolongation. Thank you, Ritrak.
Thank you so much, Mr. Chairman. With my pleasure to present my lecture today. I'm going to talk about diagnosis and management of drug-induced QT prolongation. I thought I had 30 minutes for these lectures, but I just realized that I only have 20 minutes, so I'm going to be fast. But if feel free to ask me after I finish the talk. I have no conflict of interest. And for the outline, I'm going to talk about the introduction, why QT prolongation is so important, QT measurement, how do we do it, and what is the definition of QT prolongation. And about the QT collection formulas, we have some doctors from Australia. They may say, hey, we don't do formula Right now we do QT nomogram. I'm going to talk about that a little bit as well. And we're going to talk about the risk factors for QT prolongation and torsade de poids. I'm sorry, Dr. Bruno, I may not pronounce torsade de poids correctly because it's French. Maybe you can correct me later.